What is peptic ulcer? Peptic ulcer is a break in the mucosal lining of the stomach, small intestine, or esophagus. If it occurs in the stomach, it is known as gastric ulcer. If it occurs in the duodenum, then it's called duodenal ulcer. And if it occurs in the lower part of the esophagus, then it's known as an esophageal ulcer. The incidence of peptic ulcer is 0.1 to 0.2% of the population per annum. And duodenal ulcers present earlier than gastric ulcers by around 20 years or so. And the diagnosis of peptic ulcer is a endoscopic diagnosis. The clinical features may be suggestive of the diagnosis, but it is basically essentially an endoscopic diagnosis. What is the etiology of peptic ulcers? Basically, there are two mechanisms. One which protects is a defense mechanism that protects the gastric and duodenal mucosa, and the other one is a destructive mechanism that breaks down the defense of the mucosal peritoneum. There's a balance between these two in normal individuals. In the mucosal defense mechanism are the surface mucus secretions, which contain a lot of bicarbonate ion, and this gives an alkaline environment. This defense mechanism of the mucosa is known as a gastric mucosal barrier. On the other side is the agents that cause destruction of or breakdown of the defense mechanism, and these are Helicobacter pylori, non-steroidal anti-inflammatory drugs, NSAIDs, certain foods, alcohol, smoking, and certain drugs. Acid and pepsin also act against to destroy this mucosal defense mechanism. NSAIDs can cause peptic ulceration by inhibiting the prostaglandin synthesis, which results in a reduced secretion of glycoprotein, mucus, and phospholipids by the gastric epithelial cells, which boost the defense mechanism. The interior surface of the stomach, there are numerous pits involving the whole of the mucosa, and these pits lead into pits known as gastric pits, and these gastric pits further continue as the crypts, which go into the depths of the mucosa, and these crypts are lined by mucosal cells with various specialties. The parietal cell, which secretes hydrochloric acid, the chief cells that secrete the digestive enzymes, pepsinogen, and the endocrine cells that secrete hormones. This slide summarizes the various types of cells and their functions. The chief cells produce pepsinogen, which are involved in the digestion of protein. Parietal cells release hydrochloric acid. And the endocrine cells, there are three types. The G cells, which produce gastrin. The ECL cells produce histamine. And the D cells produce stomatostatin. The cells in green, all of them stimulate the production of hydrochloric acid, whereas these D cells inhibit the production of hydrochloric acid. This slide shows you and outlines the production of hydrochloric acid by the parietal cells in the mucosa of the stomach. Okay, the parietal cell here, there are a number of metabolic processes that take place, among which the carbonic acid cycle is the most important in the release of hydrogen ions. And these hydrogen ions are pumped out with the help of the proton pump, which is also known as the potassium hydrogen potassium ATPase. And for every ion of hydrogen that is released into the lumen, 1 ion of potassium is taken into it. Okay, there are a number of receptors in the wall of the parietal cells which are stimulated by various chemicals. The vagus nerve, with the release of the acetylcholine, stimulates the acetylcholine receptors. The gastrin stimulates the gastrin receptors, and the histamine from the ECL cells stimulate the histamine receptors. All these three receptors, when stimulated, increase the production of hydrochloric acid, and thereby they increase the production of hydrogen ions. Food in the stomach causes G cells to release gastrin, whereas acid inhibits the production of gastrin, and which acts as a negative feedback on the gastrin itself. Okay, here gastrin releases hydrochloric acid, and increased hydrochloric acid suppresses the gastrin to reduce the production of hydrochloric acid. Okay, next we come to the proton pump, or the potassium or hydrogen potassium ATPase pump. Okay, which is located in the wall of the parietal cell. Okay, here this is the green one is the parietal cell. This is the proton pump. Hydrogen potassium ATPase. Okay, it actively secretes the hydrogen ions from within the cell into the lumen, and it exchanges for potassium ions. Okay, this process of production and release of the hydrogen ions are controlled by or regulated by a number of mechanisms controlled by receptors. The H2 receptors, the gastrin receptors or the CCK receptors, and the muscarinic M receptors. And these receptors are controlled by acetylcholine from the vagal endings, the G cells that releases gastrin, and the ACL cells releases histamine. So histamine, gastrin, and ACL stimulate these receptors to increase the production of hydrogen ions. And all these three mechanisms are regulated by the vagus nerve. So in the case of a patient with ulcer who is on proton pump inhibitors or H2 blockers like cimetidine or ranitidine, the production of hydrogen ions is partially blocked by the H2 receptors, and completely blocked, the release is completely blocked by the PPI. Therefore, H2 blockers induce partial block of the acid production, whereas PPI induce total blockage of the acid release of the acid. Now we come to the gastric mucosal barrier, okay, which is a very important concept. The stomach is protected from the acid by a layer of mucus and bicarbonate. Okay, this is the layers of the muscle. This is the mucosal cells which produce the mucus, and this mucus mucosal layer coats the surface of these cells, preventing it from damage by hydrochloric acid, pepsin, and also the contents of the food. This mucus layer consists of a mucopolysaccharide and produced by the gastric cells. And there's a high percentage of bicarbonate ions in this mucus, rendering it an alkaline environment. Breakdown of gastric mucous barrier can occur with bile, non-steroidal anti-inflammatory drugs, NSAIDs, and alcohol, trauma, and even shock. The high incidence of stress ulceration is because the stomach is the most sensitive to ischemia and also the slowest to recover. Now we come to the role of hydrochloric acid in peptic ulcer. Okay, hydrochloric acid appears to be vital and essential for the development of formation of a peptic ulcer. This is because of these two facts, all ulcers can heal in the absence of acid. Okay, if you suppress acid production, all ulcers will heal. Secondly, very high levels of acid, example in gastrinoma, will cause Zollinger-Ellison syndrome with multiple duodenal ulcers. Duodenal and pre-pyloric ulcers usually have high acid levels. Gastric ulcers may have normal or lower acid levels. Genetic factors and social stress are minor factors, and is clinically unable to differentiate between gastric and duodenal ulcers. Next, we come to the clinical features of peptic ulcers. Okay, first the symptom. The most important symptom complex is described as dyspepsia, which consists of pain, which is the predominant feature, which is epigastric in region, gnawing in nature, may radiate to the back, and is usually aggravated by sourish, spicy food, strong tea, coffee, alcohol, and sometimes relieved by food, although often hunger precipitates the pain. The pain is usually intermittent and not constant. The periodicity of the symptoms may appear from weeks to months and then return again. And these symptoms are usually associated with vomiting, nausea, belching, floating, and alteration of weight. Usually there is weight loss, but sometimes can be weight gain. The signs include epigastric tenderness, localized tenderness in the epigastric region with no guarding. Usually there can be pallor, and non-specific ulcer may bleed slowly. Signs of complications, anemia and melena, and usually, as I said, is unable to differentiate clinically gastric from duodenal ulcers. As for the investigations, the younger patients, means patients younger than 40 years of age, non-invasive tests for H. pylori could be done. These include carbon 13 or 14 urea blood test, serum antibodies for H. pylori, and stool antigen tests. For older patients, those with red flag symptoms or with persistent symptoms despite adequate treatment, upper endoscopy, gastroendoscopy must be done, OGDS. This can be done together with a closed test, which is a rapid urease test, and biopsy. Ultrasound and CT scans may be required when the diagnosis of ulcer is in doubt. These include to rule out gallstone disease or pancreatic disease. Barium meal, which was popular some years back, is rarely done these days. Rarely done. The advent of flexible endoscopy revolutionized the treatment of peptic ulcers. Essentially, it is both diagnostic and therapeutic in function. Previously, the fibro-optic scope. Now is the state-of-the-art improved video camera, that's known as the solid-state video camera, and also there's a massive improvement of the scope in every aspect. Not only the modern scope is thinner in size, but it also has got numerous functions, numerous functional channels in the scope that allows not only diagnosis, but biopsies, removal of polyps, and stoppage of hemorrhages, and also suction. Okay, this is a camera stack with a scope, endoscopic system, and the accessories which are laid up for the patient. Diagnostic and therapeutic. That is the important of this role of this scope, which made it a very dramatic and revolutionized piece of instrument. Gastric ulcer. Some facts about gastric ulcer. Etiology is H. pylori, NSAIDs plus smoking. The H. pylori positivity rate in a gastric ulcer is around 70%. This is less common than duodenal ulcer. Male and female about this equal ratio. Usually older patients than those with duodenal ulcer. Ulcers can be large compared to duodenal ulcer. The usual site is at the lesser curve here, lesser curve of the stomach, especially at the incisura. And the important thing about gastric ulcer, we may become malignant with time. Okay, this is a barium meal showing you a large filling defect here, crater, ulcer crater causing narrowing of the stomach. Okay, this is the endoscopic views. Okay, this is an ulcer, small ulcer, benign looking, and this is also another with possibly recent bleed. And ulcers, gastric ulcers can be classified from type 1 to type 5 depending on the site of the location of the ulcer on the stomach, as well as the acid status, either high or low. The most common is gastric body ulcer, which occurs along the lesser curve, and this has got a low level of acid. Others include ulcers along the gastric body, pre-pyloric ulcer, ulcer on the lesser curve, higher up in the lesser curve. In fact, ulcer can occur anywhere in the stomach. That's a type 5 ulcers, especially on patients who are taking non-steroidal anti-inflammatory drugs. And the pre-pyloric ulcer is of specific importance. Although it's a gastric ulcer, it behaves like a duodenal ulcer with high levels of acid. Next, we come to the complications of gastric ulcer. The gastric ulcer can erode posteriorly into the pancreas and anteriorly into the transverse colon, rarely, and this can create fistula. Okay, gastropancreatic or gastrocolic fistula. It can also erode into the splenic artery posteriorly and cause hemorrhage, upper gastrointestinal bleeding, which can be massive at times. The next is fibrosis. Ulcer heals by fibrosis, and at present this causes a stenosis of the stomach or the pylorus. It causes an hourglass contraction of the stomach, which is rare, but more commonly it causes pyloric stenosis, leading to gastric outlet obstruction or GOOP. Malignant change to adenocarcinoma of the stomach is the most important or sinister complication of gastric ulcers. This can be diagnosed by flexible endoscopy, where it is important to take multiple biopsies around the periphery of the ulcer so as not to miss the carcinoma. Okay, this is a barium meal showing you a large ulcer in the body of the stomach, which causes fibrosis and narrowing. Then here, this is the specimen showing you a hourglass deformity of a gastric ulcer that causes strangulating or narrowing of the body. Okay, creating a dilated proximal and distal segment, which is similar to a hourglass, and this is known as the hourglass deformity. Now we come to duodenal ulcers. Again, the etiology of duodenal ulcers: pylorus, H. pylori and NSAIDs plus smoking. And The incidence of H. pylori being positive is as high as 90% in duodenal ulcers. The widespread use of gastric anti-secretory agents, especially H2 blockers and PPI, and the eradication of H. pylori has markedly reduced the incidence of duodenal ulcers these days. But still, it is more common in men. Age of incidence is older patients compared to earlier. Usually at the first part of the duodenum or the D1, and fibrosis causes pyloric stenosis and gastric outlet obstruction. The other complication is erosion into the gastroduodenal artery in the posterior wall, again can result in massive bleeding. Okay, these are the endoscopic view of a duodenal ulcer in the first part of the uncomplicated, the first part of the duodenum. Here is the ulcer crater which can be seen here. All right, duodenal ulcer. Patients in duodenal ulcer may have more than one ulcer. They can have multiple ulcers. Okay, sometimes in the anterior and posterior wall. Okay, and these ulcers are known as kissing ulcers, being adjacent to each other. Sometimes the anterior wall here, the ulcer here, which can be seen here, and barium ulcer crater. These anterior wall ulcers tend to perforate, complicated by perforation. Whereas the posterior duodenal ulcers tend to erode into the gastroduodenal artery and cause massive hemorrhage. Rarely, duodenal ulcers become malignant, and it's always the golden rule that duodenal ulcers rarely become malignant. Next, we come to the important topic of Helicobacter pylori. Helicobacter pylori, or originally called the Campylobacter pyloridis, has revolutionized the treatment of peptic ulcer. In fact, it has reduced the incidence of peptic ulcer. Its eradication has reduced the incidence of peptic ulcer and even cancer of the stomach. In 1980, Warren and Marshall of Australia proved the Cox postulate true for H. pylori causing gastritis, and both of them were awarded Nobel Peace Prize for Medicine and Physiology. The important thing about H. pylori is it produces urease, which hydrolyzes urea into ammonia, which is an alkali, which causes more gastrin release, and this results in gastric acid hypersecretion, which causes more damage to the stomach. H. pylori can be tested with the CLO test, which is a commercially available urease test kit, which is performed on gastric biopsies. The urease blood test using 13C and 14C tagged urea, where the patient is asked to ingest capsules containing urea with tagged carbon, and this, as it enters into the stomach, the urease from the H. pylori splits it or converts it to ammonia and carbon dioxide, which bears the tagged carbon, and this is detected in the blood test of the patient. The ammonia that is released causes an alkaline environment for the survival of the bacteria in the acidic medium. Let's go into a bit of details into Helicobacter pylori. H. pylori is a gram-negative spiral-shaped bacillus. It is found in the mucous layer of those with duodenal ulcer in 90% of cases and gastric ulcer 70% of cases. This bacteria survives in the stomach by producing an alkaline microenvironment and induces an inflammatory response in the mucosa, leading to eventually by ulceration by invoking cytokine an interleukin-driven inflammatory response. It increases the gastric acid secretion of both the acute and chronic phases of infection by inducing the release of histamine, which acts on the parietal cell to produce the hydrochloric acid. It also damages the host mucus secretion by degrading the surface glycoprotein and downgrading the bicarbonate production. So it damages the defense mechanism, mucosal barrier. Okay, this shows the Helicobacter spiral shaped Helicobacter pylori, and this is the gastric mucosa that is damaged by the inflammatory changes brought about by this bacteria. And this is classically described as a type B gastritis. And if you were to biopsy the antral mucosa, you will get H. pylori positive. Can be confirmed by Giemsa stain. What is Zollinger-Ellison syndrome? It's a triad. It depends on three things: severe peptic ulceration. Usually, these ulcers are multiple, frequent, and non-healing ulcers. High level of gastric hypersecretion, and also incidence of gastrinomas that produce high level of gastrin and hydrochloric acid. It is characteristic finding is a fasting gastrin level more than 1000 picogram per ml. In a significant number of patients of this syndrome, they have its become part of a MEN1, multiple endocrine neoplasia type 1 syndrome. Now, treatment of peptic ulcer consists of three things: non-pharmacological treatment, pharmacological, and surgery. Non-pharmacological is very important. Lifestyle modification, avoid smoking and alcohol, change of diet to avoid spicy food, avoid strong tea or coffee, and avoid NSAIDs or other drugs, example steroids. These are all very, very important. Next, pharmacological. Antacids for symptomatic relief to neutralize the acid. H2 blockers or H2 antagonists to reduce the production of acid, and proton pump inhibitors PPI to stop the final outcome release of these hydrogen ions into the lumen of the stomach, and eradication of H. pylori. Okay, these are the medical treatment that is available. Agents: antacids, magnesium trisilicate to neutralize the acid. H2 antagonist, ranitidine or cimetidine, it blocks H2 receptors on the receptor parietal cell, thereby reducing the production of acid. Proton pump inhibitors, PPIs, such as omeprazole, inhibits the release of hydrogen into the final release of the hydrogen ions into the stomach. Sucralfate is a cytoprotective agent which complexes with pepsin and bile salts to make them ineffectively against the mucosal damage. And prostaglandins. Okay, they inhibit acid secretion. Release. Okay, this by releasing prostaglandins, they inhibit secretion, increase the endogenous mucosal defense. Next, treatment of peptic ulcer. A summary: the triple regime is the one most widely used now: erythromycin, amoxicillin, and omeprazole. The PPIs are given for 6 weeks until the ulcer is healed. Sometimes you may be repeat OGDS to ensure that the ulcer is healed before stopping treatment. Then there's something known as maintenance therapy, where patients are given half dose of the treatment dose of PPI for longer period and even lifelong, especially for patients who are elderly with multiple medical comorbid factors, which will make a recurrence of the ulcer a real risk for the patient. And also stopping of food, smoking, alcohol, and especially NSAIDs. To this PPI list of drugs, another new group of drugs have emerged, known as the potassium competitive acid blockers, which also inhibit the ATPase system, proton potassium ATPase inhibitor, and this is known as vonoprazan, which is reported to be more potent, long-acting, and early reversal of side effects, if any. Now we come to surgery. What are the indications for surgery for peptic ulcers? Less often performed these days compared to some years back. Required only in less than 20% of patients, or maybe even less. Main indication will be failure of medical treatment, and also it is essential, more commonly done for complications of peptic ulcer, which include perforation, obstruction, bleeding, and malignant change in cases of peptic ulcer. What are the surgery that is available for peptic ulcer? Basically, they are all acid-reducing procedures. For gastric ulcer, a Billrod-1 gastrectomy with gastroduodenostomy. For duodenal ulcer, Billrod-2 with gastrectomy and gastrojejunostomy. Then the various types of vagotomy, truncal vagotomy and drainage procedure. This drainage procedure becomes important for truncal vagotomy because vagotomy induces stasis of the antral part of the stomach, causing stasis, and these can cause serious complications. So in order to avoid that, you do a highly selective vagotomy or truncal vagotomy plus enterectomy. In highly selective vagotomy, the vagal trunks are preserved, but the branches of these vagal trunks to the body and the fundus of stomach are divided by a long superficial incision. Okay, just to highlight to you, surgery for peptic ulcer is rarely done these days because of the HPPI and eradication of H. pylori. Okay, these are the types of surgery. This slide shows you Billrod-1 for duodenal ulcers, gastrectomy with gastroduodenostomy, Billrod-2 for duodenal ulcer, gastrectomy by gastrojejunostomy, and these are the various types of vagotomies. This is the truncal vagotomy, okay, where the main trunks, anterior and posterior vagus, are resected, and this leads to stasis of the antral region, and then this truncal vagotomy needs a drainage procedure, which can be in the form of a pyloroplasty or gastrojejunostomy. And this is a highly selective vagotomy where the branches supplying the stomach and the fundus and the body of the stomach are transected by a long superficial incision over the stomach. The terminal ending fibers that supply the antrum and the pylorus are spared, and this is known as the crow's foot, where it's gross food is fat, the branches of the figures. Next we come to sequelae of peptic ulcer. Okay, there are a long list of sequelae or complications of peptic ulcer surgery. I will not go into the details of all this today. Recurrent ulceration is a very important complication, and this can occur in the stomach, okay, of build-up to gastrectomy. Can also present with bleeding and perforation and a gastrojejuno polyp fistula. These ulcers that recur in the stomal ulcers. Small bowel syndrome, bilious vomiting, dumping syndrome, iron and B12 deficiency anemias due to resection of the stomach, gallstones after truncal vagotomy, and not to forget, the stump of the stomach that is left behind can become malignant. Coming to complications of peptic ulcer, there are 4 major complications of peptic ulcer, which are all very, very important, and you must know more details about this. But I will not be able to discuss each of them because they are time consuming. The first important complication is perforated peptic ulcer, or perforation for peptic ulcer. Here, this is a ulcer, duodenal ulcer that is perforated, and this causes generalized peritonitis, which can lead to septicemia. The second important complication is bleeding, where, as I said, the posterior duodenal ulcer can erode into the gastroduodenal artery, which runs the posterior wall, and that could cause massive bleeding. Okay, this is a picture showing you a spurting artery from the posterior wall of the duodenal ulcer. This can cause massive hemorrhage and melena, and surgery may be life-threatening in these patients. Next is stenosis, where the duodenal ulcer over the first part of the duodenum causes a narrowing of the pylorus. Okay, and this causes gastric outlet obstruction. Okay, or GU. This pyloric obstruction causes gastric outlet obstruction, and that is a distension and obstructed stomach, which can reduce profuse vomiting. And last but not least, the malignant transformation in a gastric ulcer here. This is a gastric ulcer which over the years, over the months, has become malignant. And this can be easily confirmed by biopsy. Okay, we come to the end of the talk. Now, what are the key take-home points from this lecture? First, H. pylori and NSAIDs are the most common causes of peptic ulcer disease. Conservative management through lifestyle change and PPI therapy is the mainstay of treatment in most cases. Any patient with red flag symptoms or not responding to conservative management should be referred for urgent upper GI endoscopy. Surgical management of uncomplicated peptic ulcer disease is rare, and gastric cancer or malignant ulcer of a malignant gastric ulcer must always be kept in mind in patients who develop change of symptoms, severe anorexia, severe loss of weight, and maybe passing of melena and anemia. This will be definite signs for an urgent OGTS and biopsy. Okay, this ends my talk on peptic ulcer disease. Thank you for your patience and hope to see you again.